Hello everybody and welcome to our self-neglect webinar today. I'm just going to start our share screen so that Grace and I can square away some of our housekeeping that's important. So today's webinar is on compassionate clinical care. This is part of a three-part webinar series on neglect. The first part is exploring the grey area of older adults who self-neglect. And it's a collaboration between Western Health, the Integrated Model of Care for Elder Abuse, Merri Health and the Brotherhood of St Laurence. My name is Carla Wilkie. I'll be your moderator for today with our experts, and I'm the Elder Abuse Liaison Officer at Western Health, and I work on the Integrated Model of Care for Elder Abuse project, which is a Department of Health project that's aimed at preventing, recognising and responding well to elder abuse. My co-pilot today, as you can see on the screen there, is Grace Webster. Grace has a Master's in Social Work and currently supports older adults through social prescribing at Merri Health. She works closely with myself and Christina Micallef, who's one of our experts today, as our network partners on the prevention arm of the Integrated Model of Care for Elder Abuse. Grace will be monitoring the chat for questions and comments, and also sharing those questions with our experts today. Before we move on to our expert presentations, we've just got some essential housekeeping. So we would like to begin by acknowledging the traditional custodians of the land on which our hospitals, services and homes meet today, and pay our respects to their elders past, present and emerging. For myself, I'm on the land of the Wurundjeri people of the Kulin Nation. If you wish, please do acknowledge in the chat the lands on which you are joining us from today. And if you feel comfortable doing so, we also encourage you to write your name and the service that you're coming to us from in the chat so that you can potentially network and connect with other people who are attending. We'd also like to acknowledge the particular resilience of older people who have survived elder abuse or are living with elder abuse at this time. And additionally, if during this discussion you find that the content makes you feel uncomfortable or distressed, please feel free to disengage and participate in a way that supports your personal needs. So for public health clinicians, there's Karen Each at work on phone 84170501, and the national helplines in Australia of Lifeline Beyond Blue and Respect Victoria. I'd like to thank the Strengthening Hospitals Response Group, Strengthening Hospitals Response to Family Violence Group at Western Health for the provision of this slide, which has further family violence services that may be of interest to the audience as well as they pertain to the western suburbs. Grace, can I invite you to add any further housekeeping?
Yes, certainly. Hi, everyone, and welcome. So as Carla mentioned, I'm from the Elder Abuse Prevention Networks, and the Elder Abuse Prevention Network's aim is to support our network partners with developing interagency protocols and raising awareness of elder abuse. So if there are any attendees interested in joining the network or gaining our support with their organisation's elder abuse prevention strategies, please get in contact with myself. I'll pop my email address into the chat, and it'll also be with the final resources at the end of the webinar. And so today I'll be monitoring the chat for any questions and comments throughout the presentation. So if you have anything you'd like to share with the panelists, please put it in the chat. You can select to send it to both the panelists and the attendees, but if you would like to be private, you can just send it to the panelists and we'll keep it confidential for you. And I would also recommend switching to speaker view during the presentation. And then once the presentation's finished, switching back to gallery view in order to see everyone for the final discussion. Thanks, Carla.
Thanks, Grace. In terms of our format for today, we're bookending our presentation with a video at the start and hopefully a video at the end as well. Our first video will be a first-person narrative around self-neglect, which Micallef has provided for us, and I'll introduce shortly. And our last video is a video about that we produced during World Elder Abuse Awareness Day last year, which is "We Can Stop Elder Abuse by," finishing the sentence. So our expert presenters for today are Christina Micallef, known to most people in the industry as CC Micallef. CC is the coordinator of the Healthy Ageing at Merri Health. CC holds a Bachelor of Behavioural Studies and is completing a Master of Ageing and Pastoral Counselling. She has over 25 years experience in the aged and community services sectors and is currently leading the elder abuse prevention networks in both the north and the west of Melbourne. Our second expert for today is Amber Mills, who is a Senior Research Fellow at the Brotherhood of St Laurence. Amber's primary research interest is in improving access and provision of care services. Amber has extensive experience in research and project management roles in acute and hospital care, community nursing and aged care. At the moment, Amber is the research lead for the Brotherhood of St Laurence Critical Interim Support Program, which in short is an important case management support service for older people experiencing deep social disadvantage and self-neglect. We're really pleased to have both of you along today to share your expertise. In order to work out our content for this webinar, we asked Western Health what they would like to hear most about, and both CC and Amber are addressing that in their live presentation today. But we will be starting with Moira's story. So we would like to share with you a de-identified story told in the first person about an older person experiencing deep social isolation and self-neglect. Thank you to Ms. Trish Franklin, who is one of our fantastic consumer advisors at Western Health. She has narrated Moira's story in a very sensitive manner and was able to bring Moira's story to life, and we're most thankful for Trish's input. If you just give me a moment, I'm just going to stop the share. Here we go, almost queued up.
What really annoys me is how everyone thinks they know what's best for me. I know what's best for me. I've lived 79 years and I was born during hard times. Daddy ran out on my mother. I'm the oldest of 7 children and I helped my mother raise the younger ones. I know what needs doing and how to do it. I got enough food. I have a warm bed to sleep on. I take my medication when I feel like it, because I don't always feel like it. It makes me feel sick in the stomach sometimes, so I don't take it all the time. And it isn't hurting me. I'm still standing. And I like the way I live. There's no problem with how I live. People don't like it. They don't have to come round and bother me. I do just fine by myself. I have my dog Millie, and we take care of each other. She's all I need. My daughter, my only child, flesh and blood. She don't come round here because she knows I don't want anyone coming around and telling me I got to clean this or pick up that or tell me I'm not living right. She hasn't been here. She hasn't set foot in this house where I raised her, and I raised her just fine. She hasn't been here going on for 10 years. 10 years, can you believe it? She won't come visit me, and she won't bring her children to see their nan because she don't like how I keep my house. She says the kids might catch something. She never caught anything when she grew up in this house. She was born right here in this house. Matter of fact, she was always a strong and healthy child, but no, my house is not good enough for her children. Not good enough for her daddy either, because he shot through too, didn't he? Not good enough for my friends, anyone anymore either. Nobody likes how I live. Well, I don't care. No, they can all stay away. I do all right on my own, just me and my Millie.
Thanks again to Trish Franklin for narrating our first person story, Moira's story about self-neglect, and to CC for providing the very well written narrative. We appreciate that. So it's time to kick off with our first expert today, which is CC Micallef, to talk about self-neglect. When you're ready, CC.
Okay, thank you, Carla. I'll just have a go at sharing my screen. So I also just wanted to say thank you to Trish for that excellent narrative to kick off the topic. I'm really happy to be here to contribute to this conversation and support older people to live and age well. And our topic for today is self-neglect, and in particular, the grey area experienced by health professionals when supporting other older persons presenting with self-neglecting behaviours. So to start, we should really ensure that we are all on the same page in regards to what constitutes self-neglect. So according to Abrams et al., self-neglect is an inability or refusal to attend adequately to one's own health, hygiene, nutrition, or social needs. So there are two main categories of self-neglect that include areas of self-care, such as personal hygiene, adequate diet, nutrition, refusal of healthcare or other supports, and the misuse or refusal of medications. The second area for self-neglect is environmental and may present as hoarding, squalor, uncontrolled infestations such as vermin in the home, and or neglect of general maintenance that supports safety within the home. So self-neglect is an insidious public health issue on the rise across the entire globe. It is likely to increase in severity over time as we age, and self-neglect does not discriminate and can occur across all demographics and social economic statuses, just as often among the middle class and the very wealthy as in poor communities. So importantly, ongoing self-neglect can lead to increased frailty and cognitive decline that is not otherwise related to the normal aging process. So it can be quite detrimental to someone's health if it continues. And most individuals who self-neglect remain functionally capable with little regard towards the risks posed to their health. So interestingly, in Australia, self-neglect is not classified as a form of elder abuse. This is largely in part to the importance placed in Australia on a person's right to both personal autonomy and self-determination, especially in regards to how a person may choose to live. So this is despite international studies identifying self-neglect to be the most common form of elder abuse, closely associated with increased morbidity and mortality, and which has led to investigations and discovery into common predictors for self-neglect, including physical decline and social withdrawal. So into the grey area. This occurs when respect for patient preferences and their right to personal autonomy conflicts with medical opinion or the desires and needs of others, such as family, powers of attorney, or carers. And this could include assumptions made regarding an older person's decision-making capacity, differing perceptions of health or risk, whether or not the person is simply stubborn or eccentric, if their problems are largely or otherwise preventable, what sort of burden their behaviour is placing on already stretched health services, the practitioner's duty of care to prevent harm and minimise risk for their patients, and even that difficult balance between relieving families of unnecessary burden or other adverse effects and impacts that the self-neglecting behaviours bring about within the family unit. So when considering the lives of older people holistically, an attack on personal freedom may simply compound other existing issues of aging, such as increased frailty, disability, vulnerability, role changes that come with age, dealing with grief and loss, and other threats to identity and autonomy. So often this can lead to a feeling of not being in control of one's life. And for many older people, unwanted increased dependency may preclude a retreatment from life and withdrawal from social connections and self-care. So from the outside, it may appear the self-neglecting individual is just creating preventable problems for everyone. The grey area illustrates how respect for client preferences can be at odds with medical opinion. And this is often at the heart of an existing ethical obstacle with it, which inhibits not only an appropriate offer of help, but also the acceptance of support among older people who self-neglect. And add to this ageist attitudes that undermine the value and potential of older people. And it's not surprising that many older people perceive that the very act of growing older comes with an erosion of power and independence that may have negative impacts both mentally and physically. So where does this leave health professionals struggling to support or care for an older person who self-neglects? And how do we best balance patient safety against the very human need to be treated as autonomous individuals? And this is especially when we consider that self-determination as expressed through the choices we make define a sense of self and the purpose that gives meaning to life. So unfortunately, many health professionals feel quite overwhelmed. They find it difficult to navigate the ethical issues between duty of care and supporting the autonomy of the older person. And there's also a lack of framework or best practice approach readily available to guide us in supporting someone presenting with behaviors of self-neglect. So when considering an individual who is otherwise capable but non-compliant, many clinicians attempt to work solely within a model of informed consent. Now, while gaining consent is a requirement, informed consent has long been acknowledged to be at risk of leading to value-laden appraisals by way of intercession in order to make needed decisions on behalf of the client. So if in doing so, we show a lack of consideration for an individual's right to self-determination, as expressed through the choices a person makes, such as their right to refuse medical treatment or eat nutritious foods, we run the risk of employing intrusive measures or unintentionally enforcing our own biases and values that may override the freedom of the older person. So this includes attitudes acted upon in the supposed best interest of the individual, leading to personal preferences being overridden or treatments imposed against their wishes. So the challenge then lies in the middle ground, in maximizing opportunity for advocacy, empowerment, and persuasion, and the individual being capable but resistant, or resistant but somewhat, though not legally, impaired. It's important to understand that for older people, especially those in the grips of decreased functioning, choosing to neglect basic needs may actually be on a certain level in attempt to exert some form of control in their lives, even at the detriment to their own health. Accordingly, researchers have attempted to determine predictors of self-neglecting behavior by considering commonalities between people who self-neglect. So under constructionist grounded theory, a need for continuity can be a very strong motivational force for behaviors whereby an individual makes adaptive choices to preserve and maintain existing structures in order to protect the self and maintain customary control. So essentially the term self-neglect in this instance becomes a misnomer, as an older person labeled in this way may actually be in a process of struggling to maintain a coherency of self, with their actions either adaptive or maladaptive geared towards preserving and protecting identity and staying in control within their own protective environment, which contrary to what is actually being displayed, may be an attempt to present themselves as competent human beings. Thus self-neglect, such as social withdrawal or refusal of health care, may essentially be an outward display of maintaining continuity through self-preservation and even survival in the life of the older person. To put it another way, often in response to age-related decline or major illness, attention to self-care may be the last area of functioning whereby an older person is still able to exert a semblance of control. In the same way, interpersonal conflict may be impacted by pride and trust issues, with self-preservation a common response to relationship breakdown. So not surprising, health services working in the grey area of self-neglect may be unsure how to proceed and what should be considered when supporting an individual too proud to accept help, or who may lack trust in others, or who is determined to remain in control. Well, there's a couple of things that should be considered when working with someone who self-neglects. And the first of these is the person's level of social engagement, which is gaining increased recognition through the advancement of social prescribing to support mental and physical well-being, first in the UK and now worldwide. Social engagement by way of community connection and participation has been shown to give meaning and purpose in the life of older people. And this is true for everyone, really. However, it does assist with maintaining a sense of youthful independence for the older person. Unfortunately, older people who self-neglect have far fewer social resources and often live in isolation from others. In particular, social isolation in the form of family estrangement and social withdrawal from friends and community is like an existence without the benefit of social anchors or the necessary supports to buffer in times of stress, illness, or suffering. Essentially, social anchors can act as boundary umpires that guide socially acceptable and expected behaviors, especially in relation to personal hygiene and living environment, as your friends can be useful and often not afraid to remind or cajole us out of mental or emotional lethargy. In addition to social anchors, another important consideration in the lives of older people who self-neglect is the role of meaning. So more and more research is showing that meaning plays an important role in mediating illness, decline, and relationship conflict. Meaning also aids in the universal human impulse to construct a sacred reality. And sacredness in life is different for everyone and can be expressed through faith or religious observance. But importantly, it can also be expressed and understood more secularly by way of art, music, creativity, a connection to nature, community, hobby, or activity. So meaning brings hope. It opens the door to intimacy with others. It transcends disability and loss. And a search for meaning can become an essential task of the aging process. So attention to meaning is gained through the process of attending to the spiritual tasks of aging, such as a need to give or receive forgiveness and reconciliation with others, may lead to improved social connections and the creation of renewed or new social anchors to support an older person to address self-neglecting behaviors. So the lived experiences and personal histories of an older person become important. And these may unlock clues to unmet spiritual needs disguised as withdrawal or refusal to fully look after one's own health or reluctance to maintain a healthy home environment. And how do we unlock what is sacred and what gives meaning for an older person? Well, to unlock meaning and understand someone's sacred reality, listening is a good place to start. Listening is a vehicle for carrying meaning and may assist in reflection, renewed clarity, or change in perception of the past, themselves, and others. So we build rapport and understanding as we listen to the narrative histories of a person, and we assist them to find meaning and purpose, which can then lead to a resolution of past trauma or conflict, as the very act of listening encourages reflection that affirms identity and renews a sense of self. The act of reminiscence may also offer realization through the validation of the past, or even the acceptance of a new or different perspective gained through the sharing of their story, leading to a new meaning or a new sense of self that negates the continued need for control and opens up possibilities of a way of being that enhances more than diminishes personal health and well-being. When giving opportunity to an older person to tell their story, it's important to pay attention to the language used, which may assist in identifying centers of meaning and what is held sacred by the individual. So within this context, let's reconsider Moira's story and the clues her lived experience may offer in regards to underlying unresolved spiritual tasks of aging, disguised as social withdrawal and self-neglecting behavior. Within Moira's story, there were several clues to underlying issues, which may be impacting on Moira's need to exert customary control regarding her health and her environment. For example, Moira's narrative history highlights hard times, including an absent father, having to support a mother to raise younger siblings, and there's also evidence of multiple relationship breakdowns. And it is the quality of relationships that has been identified as an important vehicle for bringing meaning into people's lives. So notably, Moira has become estranged from her family and has withdrawn from social circles, probably more and more in response to how she perceives others think about the way she lives. But initially, this may have been a reaction to underlying issues such as past trauma, unresolved feelings of abandonment, first by her father, then her own partner, daughter, friends, friendship circle, etc. So it leads to the question, has anyone, any health or support service provider or GP, attempted to address the issues of social isolation or relationship estrangement, or taken the time to consider the outward expression of self-neglect as a response to unresolved past trauma? Because once these unmet spiritual needs are addressed and meaning and purpose returns to the life of the older person, there is a renewal of spirit, so to speak, a new spark for life. And areas of self-neglect can be more easily addressed when the need for customary control is reduced and the older person becomes more open to actions that support and improve their overall health and well-being. So listed here are some references for future reading and research, and we will be sure to include this information with the resources that will be sent out following this webinar. And I might take a moment now to ask Grace if there's any questions in the chat before we move on to Amber and the information regarding the Clinical Interim Support Program.
Thank you so much, Cece. That was such an insightful presentation. We have actually had a few questions that have come through the chat, which is great. Thank you. If you have anything, please send any questions or even comments through. So we have one here. So Christina, any thoughts on dealing with compassion fatigue for workers dealing with this client group longer term, given that there are no quick fixes?
Yeah, so I guess it depends on where, you know, what sort of industry or sector you're working in and what your responsibilities are, because, you know, for clinicians in a hospital setting, for instance, you know, they need to understand it's not necessarily it's not their responsibility necessarily to solve these problems. And there are professionals and services available who can more directly assist with addressing self-neglecting behaviours. However, everyone should demonstrate appropriate listening that maintains an awareness of language so that they can, you know, appropriately refer when they identify a need. But compassion fatigue, I guess it's all about ensuring that you have a plan for your own self-care, because more and more, if you're dealing with, and like I said, if you're dealing in aged care, self-neglecting behaviours, you know, they increase with age. And so if this is something that's presenting to you in multiple times, if you don't have your own plan for self-care, if you're not taking steps to make sure that you're receiving appropriate clinical supervision, you know, even your own, you know, tapping into workplace employee assistance programs and things like that, but also emotionally, you know, so doing things that you love and that is sacred to you also is helpful, because at any stage that we're at, our need to connect to the things that give us meaning and purpose is what helps us through those difficult times.
Great answer, thank you. And there's a few more questions that have come through. I'm just mindful of the time as well. So I might just introduce our next expert, and then at the end we'll have more of the time for more questions for Cece, or for our next expert today, who is Amber Mills. And she'll be talking to us about the Critical Interim Support Program at the Brotherhood of St Laurence. This program draws on many of the principles of care that Cece has spoken about today, to deliver more intensive support to an older person experiencing deep social isolation and self-neglect. So welcome, Amber.
Thanks, Grace, and I'm very happy to be here today to talk about our program. My role on this project is with the evaluation component, and I'm presenting today on behalf of our two case managers and a program manager. So the Brotherhood of St Laurence works in a number of settings, and this program comes from our aged care division. We're an approved aged care provider, and we specialise in working with older people experiencing disadvantage, including limited financial resources and social isolation. The program began with asking our home care package case managers to try and take on one unfunded person each in their caseloads. We did this because we know that some older people were falling through service gaps and experiencing a significant deterioration in their health and wellbeing, either because they're unable to engage in the My Aged Care assessment process at all, or because they experience long wait times for home care packages and are unable to arrange essential support services in the meantime. We know that during any time without supports, this cohort's circumstances often worsen, leading to a deterioration in their living environment and physical and mental health, including a heightened risk of homelessness, premature placement in residential facilities, for example. So this program is a 2-year funded pilot and evaluation, and we're funded by the VAL Foundation. The pilot addresses our observed service gap in the aged care system, working in an assertive outreach capacity with old people in vulnerable situations. We provide short to medium term intensive case management to address initial crises, guide them through the My Aged Care assessment process, and also link them with the essential services that they need. So in that sense, the essence of what we provide is a connector role and a crisis solver role, but that's only possible once initial trust and rapport have been established, which often is a very intensive piece of work. Linking back to Cece's earlier comments, the core of the work is about listening to clients and working with them to understand how we can best provide some support. In terms of intake criteria, we work with people aged 65 years and over who have limited financial resources and social supports who are currently living in the community. Our catchment areas that we work in are located around the Frankston and Sunshine service hubs, and we have a case manager located at each of these hubs. In terms of exit criteria, our clients only exit the program once home care packages, for example, are in place or when a sufficient number of interim supports are in place. So in that sense, the program doesn't have a definitive time limit on it. Our approach is trauma-informed and person-centred. So that means we anticipate the prevalence of trauma in the histories of the clients we work with and recognise the many ways symptoms of trauma may be evident, such as in a person's appearance, their language, or exhibiting challenging behaviours. We also work in a way that will best meet client goals, aspirations and needs. As part of this, we work with the Dignity of Risk template to understand a desired outcome for the client, to consider the nature of risks undertaken and their ability to make an informed choice, such as personal choices to smoke cigarettes. All of our clients have provided consent, informed consent to work with the case managers. In terms of program outcomes, we're 4 months into this pilot project and we began in September of last year. We've worked with 23 clients and are well on track to meet our target of 50 clients in the first year. The clients have been split across single and shared living arrangements. Of those who live with others, 6 were in very challenging family situations where they lived with people who experienced severe and long-term mental health issues. 8 clients exhibited hoarding behaviours and 10 had notable concerns about weight, being either extremely under or overweight. Referrals to the program have mostly come from the aged care assessment system, ACAS or RAS, for clients that they themselves have held concerns about, either because the client was resistant to engage or wouldn't let them into their homes to undertake an assessment, or because of concerns about how a client would survive the wait time for package supports. This demonstrates a recognition within that assessment system of the unmet need. Referrals have also come from the Western Hospital, and one was a joint referral with an elder abuse project officer. To date, brokerage funds allocated to the program have been spent on industrial cleans, a private nursing service where there was an immediate need for medication support, mobile phones for clients who don't have any phone access, and food supplements. In terms of workload, both case managers are stretched due to demand in what is proving to be a vital service. It is intensive work for the most part, and unlike package case management work, there's not the infrastructure of administrative staff, for example, to help with coordination, partly because of limited funding and mostly because the clients we work with are often very distrustful of others. We now have a 3-week wait list in both regions, and this is something we have mixed feelings about. There is a very clear need for the program, and we want to give an accurate picture of what we are able to do. So some more acute cases have gone elsewhere for immediate support. However, many of the clients we work with have refused services or not acknowledged need for services for some time. And in those instances, 3 weeks is sometimes an okay or an acceptable wait period. The work also has its extremes in terms of load. For those clients who do require only a light touch support, the case managers are helping existing people in their lives, such as family members, friends or neighbours, to continue supporting them while checking on the wait time for their package, or assisting them to access interim support services through the Commonwealth Home Support programs. At the other end of the scale, case managers are sometimes the only person who the client will allow in to their home or agree to speak to, and this can take many, many visits over some time to gain that trust. Often it's a small task or objective that literally opens the door, and from there begins a range of activities, from dealing with the initial emergent needs, food, phones, medications, etc., to arranging for appliances to be fixed, getting agreement for industrial cleaning, and arranging for assessment and access to other services. To date, of our 23 clients, 8 have been discharged from the program. In terms of emerging themes from the small amount of data we have collected so far, very clearly there's an intersection with the health and hospital system. In the absence of rigorous discharge planning, especially for patients with extended admissions, or when knowing that repeated ED presentations have other non-medical underlying causes. At the Western Hospital, for example, the ED and ward staff have connected with our case manager and referred discharged patients for support to help assist with the transition back home, arrange food, make sure the utilities are still connected. One of our clients needed help to get their pension payments restarted following a very lengthy admission in hospital. The barriers to seeking support, as CC has already outlined, are highly complex. Some clients we've worked with have demonstrated very little insight into the issues presented by their current situation. For others, they have not understood how or where to seek support, but recognise that they do need support. One example we have is a client who presented to the local council having been discharged home following a stroke, needing help and unable to make sense of the information that had been provided on discharge for the hospital, and the council was able to connect us in with that person. Mental health challenges are significant, both for clients and their families. As I mentioned, 6 of the 23 clients had family members with severe mental health issues living with them, and this in and of itself presents a barrier to the older person to engage with assessment processes and support services. Previous attempts of support to the older person have either constantly failed or never got going in the first place. Social isolation, even when living with others, can be compounded by verbal abuse or paranoia on the part of the other family members. And this is leading to some intersection for the program with elder abuse services. Hoarding and squalor have been another significant issue, with 8 of the 23 clients to date having experienced these issues. Most of the hoarding is about objects or items. However, we do have one pet hoarder. This client is currently in hospital and her 50 cats are being rehomed. Several clients exhibiting hoarding behaviours were embarrassed by the state of their environment and therefore have not let services into their home. In other instances, previous trauma has resulted in a distrust of authorities and services. Most of the hoarding seems to result from passive neglect over time, rather through constant acquisition and a real trauma of losing items. And I guess on that point, I think that really exemplifies what CC was talking earlier about the issues of customary control in driving these sorts of behaviours. So finally, as a point of difference, clearly we're not the only organisation working with people in precarious situations, but we think there are some unique differences about what we're trying to do. We provide an outreach service. The support is in the short to medium term. It's intensive case management until the client is connected in with the most appropriate services, and we remain in play until the client is ready to transition. This means the case manager then becomes the linchpin to coordinating other services, and the clients often become very reliant on our critical interim support case manager, having taken some considerable time to establish those trusted relationships. In some instances, the CIS case manager is staying on with the client when transitioning over to a home care package case manager until the client feels comfortable. The work being undertaken is navigation, but it's more than that. It's connecting people to services when there are various barriers, and it's building connection between agencies and service providers. In cases requiring the most intensive work, there is a notable point of difference. I think some of the examples of the lighter support could be undertaken by other agencies, for example, the access and support programs with CHSP funding. But the more intense scenarios that some of our clients are living in highlight the impact of deep isolation and neglect and significant social isolation and withdrawal, and the resulting inability to connect in with community. So I'd probably leave my discussion there to see if we have any questions for both myself or Cece. Thank you.
Thanks, Amber. There was a quick question in regards to eligibility for your service. Is it limited to those who only have BSL home care packages, or open to?
Not at all. No, not at all. We have some clients who end up taking a home care package with us, but we have provided assistance for clients to have access to information to any other provider. So yeah, not just limited to our services.
Great. And we've had a few people comment of their service also available. So like you mentioned, that there are quite a few different services out there.
Right.
So we have Tash from Vincent Care, with the CHSP social workers for people aged over 65, as well as Glenn from the Northwest Hoarding and Squalor Network. That's available as well. So this is all different information that we can send through, but also on the slide now that we have the Brotherhood of St Laurence, the contact details, as well as Merri Health, SteppedCare for older adults mental health support, as well as the Living Well, Aging Well diversional therapy support services available as well. So thank you for that presentation, Amber.
Thanks, Amber. Thanks, Grace. Grace, do you have anything more to add? I think in terms of, we're moving into our panel questions now. So I think people need to switch screens. Is that correct?
Yeah, if people would like to switch into the gallery view so you can see everyone's faces during the discussion. And yeah, do you want to kick us off with our first question, Carla?
Lovely. So we've had some questions submitted pre-webinar for our experts to address. For CC, do clinicians need special skills or training to work with older people experiencing self-neglect?
Thanks, Carla. Yeah, so I think I was touching on this earlier too, because it seemed to be something that the participants watching were interested in as well. So it's important for clinicians to understand their responsibility isn't necessarily to solve these problems, and there are services available, which we've just heard about, that can more directly support those issues. So as far as skills and training goes, I think everyone should demonstrate appropriate listening that maintains an awareness of language that may give an indication of possible drivers in regards to supporting these or identifying these types of behaviours. Because listening is what unlocks the clues in the lived experience and story of the older person, especially in what they hold sacred and what might give them meaning, and as well as any unresolved spiritual tasks in order to support them through appropriate referral. So it's important that practitioners understand that customary control, which Amber also alluded to, is an incredible driving factor for non-compliance, and not simply the older person being difficult or unaware of what is actually good for them. So acknowledging a need for self-preservation and that customary control can go a long way in the provision of compassionate care that upholds the dignity of the person.
Thanks, Cece. We had another question submitted pre-webinar What needs to happen to promote better attention to spiritual unmet needs for people accessing healthcare, and how would we integrate that with the current model of healthcare?
Yeah, so in Australia, health and aged care service providers working with older people are expected to provide care and services that reflect social, cultural, language, religious, spiritual, psychological, and medical needs. So if you're looking in particular, standard 1 of the aged care quality standards is centered around consumer dignity and choice, and to treat older people with the required level of dignity and respect that maintains their identity. And this allows for informed decision-making regarding the care and services they receive and to live how they choose. And this includes valuing individual cultures, diversity, and spiritual care needs. And in particular, in 2016, the National Guidelines for Spiritual Care in Aged Care was introduced. And this document is an excellent resource for understanding how to best support the spiritual needs of older people. The guidelines point out that spiritual care is about growth and flourishing, and is vitally important in bringing meaning, purpose, and wholeness to assist people to flourish, grow, and realize their potential as they age. And this reinforces the concept that spirituality is part of everyday living, and hence all those who have contact with older people can actually share in that spiritual journey.
Thanks, Cece. I had a question for Amber as well. What role do you think clinician service providers' personal biases play in how they respond to older people experiencing self-neglect? And how would you suggest that we navigate that as a service or as individual clinicians?
Thanks, Carla. I think personal biases can impede recognition of what are self-neglect behaviours. Because we may perceive that a person presents with difficult behaviours or they're unwilling to engage, etc. And as Cece has talked about in her part of the presentation as well, I think the key is to ask why and look for the clues as to what is needed and what is underlying, what's the driving force between these sorts of behaviours. I think personal biases may also come into play when considering what's the right course of action or the most appropriate course of action. And I think the key there is to keep it person-centred.
Thanks, Amber. I'm noticing in the chat, Grace, that there's an awful lot of questions. So if we don't get a chance to get to them all today, we'll definitely shoot them through to Cece and Amber so that they can answer them and send them out to all attendees, because I'm sure everybody is curious about the same sorts of things. The other question that we've had submitted was around where these services fit in the landscape of current services. And I know Grace mentioned some existing services that have been written into the chat. So Glenn from Northwest Hoarding and Squalor Network and Tash from Vincent Care. Where does the critical interim support program fit in the landscape? And are there other services out there that will be quite helpful as well?
Thank you. I'm really encouraged to know that there are other people working in similar services on the webinar today, and I'd love to connect with you. As I mentioned in my presentation, we're clearly not the only service provider working in this area, but I think what we're trying to do is help bridge the silos or bridge the gaps in a fragmented care system, and that fragmentation comes about because of different funding streams and different program jurisdictions. So we're trying to connect people in with services and also provide connection across those different services. And I think that sometimes the fragmentation in that system can make it harder initially. And so what we need to do is shake the tree to make sure that we can put the best resources out there to provide assistance. We have got our contact details up on that slide, which I know you'll share around, and I know Merri Health have some services as well, and obviously the ones who've self-identified in the chat. So it's great to be able to help see what's out there and provide connection.
Thanks, Amber. Cece, do you have anything to add to that in terms of other services in this space?
Yeah, so I think it's important that services that blend mental health support and community connection are particularly important, such as Merri Health's SteppedCare wellness and mental health support for older adults. So this service operates throughout the North and the West and combines psychosocial and clinical interventions to improve health and wellbeing and reconnect people over the age of 65 within their community. And in the Moreland and Hume regions, Merri Health delivers a targeted social prescribing service to people who are 50 years and over. And it focuses on health education, building skills around activities of daily living and social engagement and community participation. And that's the Living Well, Aging Well program. So it's important to be aware of services that are available so that when an area of need is identified, there's an appropriate service for referral.
Thanks, Cece. From my perspective, I'm really curious to know, as a fellow clinician as well, what's the single most important thing clinicians in health and social services can do with this cohort of older people experiencing self-neglect? So maybe the next time they encounter an older person experiencing self-neglect. Maybe Amber first.
I guess I addressed this when you asked the question about personal biases. I think be aware of them and be curious as to what's driving the person's behaviour and why they might be coming to see you. Be curious about what's sitting underneath the surface, I guess would be my response to that.
Yeah,
Thanks,
and I think that if I added something to that, I just think that we need to make sure that that we come from a place of compassion and view the humanness of the person. So ageist attitudes of grumpy, stubborn old people, it just denies the individual their dignity. And we need to see beyond the behavior and take the time to listen in order to hear what's really going on for that person.
Thanks, Cece and Amber. I know that we as a group have talked a bit about going slow to go fast. So the importance of getting to know people, getting to know what the unmet needs are for individuals in order to then be able to support them moving forward. Do you have anything else to add, Grace?
There was a few things in the chat. I am mindful of the time. The last one that came through was just wondering if there was someone we felt needed help, who would you recommend we turn to first? Who would people say would be the first point of call?
Can I point out that we have the integrated model of care for elder abuse. What a beautiful segue that was. So there's 5 networks. So Western Health has one, Melbourne Health has one, Peninsula Health, La Trobe Health, and Monash. So these are we're I guess a project that has 4 prongs. So the first part of the project is related to workforce training, where there's free approved workforce training. But the second part of the prong is the elder abuse liaison officer, which is one of the roles that I feel, and I know some of my colleagues from the other networks are on today as well. And our role is to support clinicians with secondary consultations as to where to from here, where they suspect elder abuse, where there's a disclosure of elder abuse, or where there's risk factors. And of course, people who are experiencing self-neglect are at a higher risk of other forms of elder abuse as well. So I would suggest that we could be our first point of contact in order to suggest which services and which supports might best suit individual clients.
Great. Do we have time for any other questions, or I'm just mindful of that? We can answer there's been some fantastic questions that have come through. We can answer them offline as well. What do you think, Carla? Do we have time for one more?
I did see that there was a question around talking about what is deep social isolation or severe social isolation. I'm just wondering if our experts can speak to that as well. Maybe Cece?
Yeah, so the deep social isolation is what I described earlier, where someone is without any social anchors, the social connections that would provide, the support during chronic illness, stress, and other issues, frailty, those sorts of things. And without those social anchors, someone can be very introspective and not have their eyes open to what's actually happening around them. They can go into, some mental health issues, low mood, depression. Can lead to lots of things if you don't have someone that can be that person to cajole you out of your lethargy, so to speak. I think I guess that's really what it is. Someone who is completely isolated in the home, is not responsive to supports, doesn't is without community connections. I guess if you really want to picture it, it's that person who you see on the news who has died and no one has known. That would be deep social isolation.
Thanks, Cece. Do you have anything to add to that, Amber?
I'd probably add that I think it also, what Cece's just described also reflects the range of complexities that arise from being socially isolated. It's not just the absence of connection, it's the consequence of that. So when we use the word deep social isolation as opposed to severe social isolation, I guess that's the other distinction we would be making.
Thanks very much. There has been some questions in the chat, I know, about different presentations with self-neglect. We will be having some subsequent webinars on unintentional neglect, but also on diversity and neglect, which will hopefully start to address some of those concerns as well. Does anyone have anything else to add? I'm just going to reshare the poll. If we could get that done again, one moment. Relaunch the poll. So if you wouldn't mind re-answering the poll that we did at the start, that would be great. Oh, fantastic. Everybody's doing it really quickly. Many thanks for that. Grace, do you have any other questions you'd like to pose while we just give the poll a minute?
Yeah, there was one that I thought was quite interesting, and it is, sorry, let me just find it. Why is self-neglect considered to be a growing issue? Or is it just about the number of older people, or more a reflection on our society?
That's a very deep question, because self-neglect is not just an older person's issue, though it does tend to increase as people age. So I guess there's probably lots of, that's a bit broader question, and lots of all the intersections that might come into play in regards to self-neglect. But I guess if you go back to the reasons of self-preservation, that need for control, that even though someone is presenting as self-neglecting, they are not perceiving it that way. They are perceiving it as that being their last sort of way to keep control of their life. They're living the way they want. No one can tell them different. So it is that maintaining that customary control as a driving force. And that could be in any situation at any age.
Thanks for that. Just in terms of our shared poll results, so our initial poll had people at somewhat confident at 40%, confident with support at 42%, and completely confident at 12%. So we can see that that's we've improved across the board. So somewhat confident now at 19%. Most of those people have moved into confident with support or completely confident, which has gone from 12% up to 27%. So I think that's everything from both of our presenters. Thank you everyone for participating, for coming along. We had a lovely turnout, quite a large turnout. A big thank you to our special guest expert presenters, Christina Micallef, CC Micallef from Healthy Aging Service at Merri Health, and Amber Mills from the Critical Interim Care Program at the Brotherhood of St Laurence. And again, we're most grateful to Trish Franklin, our consumer advisor, or one of our many consumer advisors at Western Health, who's also our consumer advisor at the Integrated Model of Care for Elder Abuse. So we're very thankful for her input. And also from myself to Grace, thanks for your hard work and collaboration, really well done, with the back-end support and the preparation for the webinar. you have anything else you might like to share, Grace, before we finish up?
No, just a reminder that the elder abuse prevention networks are here to support organisations with their response to elder abuse prevention. So my details will be on that resource sheet that we send out, and feel free to get in contact if you have any questions at all about it.
Thanks, Grace. So I'm just going to share our the video that we did last year just to close the webinar. Thank you again. And hopefully we'll see you at our next webinar on unintentional neglect at the end of next month. So stay tuned.
Thank you, Carla.
Most welcome.